I am the liver. Cirrhosis is the chronic replacement of my normal tissue by scar and regenerative nodules. Cirrhosis develops over time, as repeated injury leads to fibrosis and nodular regeneration. Fibrous bands divide my tissue and distort normal blood flow inside me. This architectural distortion raises pressure in my portal circulation. Portal hypertension is a key consequence of cirrhosis. High portal pressure creates varices that may bleed catastrophically. Reduced plasma oncotic pressure and portal hypertension cause fluid to collect as ascites. Collateral circulation appears on the abdominal wall as caput medusae. Hormonal changes and vascular abnormalities cause spider naivety and palmar erythema. Cirrhosis alters sex hormones, producing gynecomastia and testicular atrophy in males. Impaired bilirubin handling leads to jaundice in advanced disease. When I cannot clear toxins like ammonia, brain function is affected and encephalopathy develops. Ascites and altered consciousness are clinical signs of hepatic encephalopathy. I produce clotting factors, and cirrhosis causes coagulopathy with prolonged INR. Reduced albumin synthesis lowers oncotic pressure and contributes to edema and ascites. Severe cirrhosis can trigger hepatorenal syndrome, a functional kidney failure from circulatory changes. Ascites predisposes to spontaneous bacterial peritonitis, a dangerous infection of the fluid. Cirrhosis greatly increases the risk of developing hepatocellular carcinoma. Portal vein thrombosis may complicate portal hypertension and worsen symptoms. Common causes include long-term alcohol use, chronic viral hepatitis, non-alcoholic fatty liver disease, autoimmune and metabolic disorders. Chronic toxins and metabolic stress promote hepatocyte death and progressive fibrosis. Persistent viral infection triggers continuous inflammation and scarring. Genetic iron or copper accumulation causes direct liver injury, leading to cirrhosis. Clinical examination finds a firm nodular liver, enlarged spleen, and signs of fluid in the abdomen. Lab tests show patterns, enzyme changes, rising bilirubin, low albumin, prolonged INR, and thrombocytopenia. Ultrasound is the first-line imaging to detect liver surface nodularity, portal hypertension, and ascites. Fibroscan, or elastography, measures liver stiffness as a non-invasive surrogate for fibrosis. CT or MRI provide detailed structural assessment and can detect focal lesions or malignancy. Biopsy can confirm diagnosis and stage fibrosis when non-invasive tests are inconclusive. The Child-Pugh score combines labs and clinical features to estimate cirrhosis severity and prognosis. The MELD score predicts short-term mortality and prioritizes transplant allocation. Key treatments include removing the cause, stop alcohol, and treat viral hepatitis or metabolic disease. Nutrition management and salt restriction help control malnutrition and ascites. Diuretics are first line to mobilize ascites, with careful monitoring of electrolytes and renal function. Large or refractory ascites are managed with paracentesis and albumin replacement when needed. Variceal bleeding is treated with endoscopic banding and vasoactive drugs. Prevention uses beta blockers and surveillance endoscopy. Hepatic encephalopathy is treated by lowering ammonia with lactulose and non-absorbable antibiotics. Spontaneous bacterial peritonitis requires prompt antibiotics and diagnostic paracentesis. Hepatorenal syndrome is managed with vasoconstrictors, albumin, and renal support while addressing liver failure. Regular surveillance for hepatocellular carcinoma uses ultrasound every 6 months with AFP monitoring. Liver transplantation is the definitive treatment for decompensated cirrhosis when medical therapy fails. Preventive care includes hepatitis vaccination, alcohol cessation programs, and control of metabolic risk factors. Prognosis depends on disease stage, complications, and response to therapy. Regular follow-up is essential. Understanding cirrhosis, from causes and pathophysiology to complications and transplant, guides